Good afternoon. Today's first TED-like talk presenter is Cho-Hee Shrader, a PhD student in Prevention Science and Community Health in the Department of Public Health Sciences at the Miller School of Medicine. The title of her talk is, What is Homophily and How Can It Halt HIV?
Flags. Each of these flags represents a country or an island that I've grown up in. As I moved from country to country, it was easy to fall in love with all these different and diverse cultures. However, as a public health enthusiast, I noticed one striking pattern in every single country I lived in, and that was the presence of health disparities. Health disparities are when one group experiences a higher burden of disease relative to another group. While I expected this in post-apartheid South Africa, or perhaps some of these more developing countries, I did not quite expect to see this here in the US. One striking health disparity to me here in the US is the HIV health disparity that is experienced by sexual and ethnic minority communities. In cities such as Miami, the epicenter of the HIV epidemic in the US, this is even more alarming. This is what the HIV health disparity looks like in the US. About 1 in every 524 heterosexual men are estimated to be diagnosed with HIV by the age of 50 if current trends persist. This number is 1 out of every 253 women, and for Latino gay men, this number is 1 in 5. For Black gay men, this number is 1 in 2. This is an alarming health disparity, especially because we have biomedical prevention strategies such as pre-exposure prophylaxis or PrEP. PrEP is an HIV preventive medication that when taken daily can reduce the risk of getting HIV by up to 99%. The way PrEP works is by going around and surrounding your immune systems or your immune cells. It prevents HIV from getting in and replicating, so your body will not seroconvert to HIV if you take PrEP daily. However, as we have seen HIV-related health disparities, there are also PrEP disparities in the US. For example, the CDC estimates that 1.1 million people could benefit from PrEP. About 44% of this population is estimated to be Black or African American. However, of everyone prescribed PrEP in 2018, only 1% were Black or African American. The CDC also estimates that 25% of people who could benefit from PrEP are Latino. However, only 3% of those who were prescribed PrEP in 2018 were Latino. This is a PrEP disparity. This is unacceptable. Currently, scientific methods to address these health disparities have used traditional random sampling. However, these don't account for the unique interaction of people with others. It doesn't account basically for their networks. My mentor, Dr. Mariano Kanamori, is doing his research on the social networks of minority communities. And within the field of social networks, one theory that I particularly came to love is the theory of homophily. So homophily is when an individual is attracted to other individuals based on a shared similarity or common attribute. So what does this look like? Well, basically, what this looks like is that if you and I are both women, we're more likely to be friends. We're more likely to share health-related information. If you and I both lived in one of these 9 countries that I showed you the flags of, you and I are more likely to model each other's health-related behaviors. However, the tendency for homophilous networks is to exclude information from other networks. For example, majority networks tend to hold on to information, not because they necessarily try to, but because that is how information travels. And this prevents minorities from minority networks from accessing this health-saving information, for example, like for PrEP or HIV prevention strategies. However, there is a way that we can increase the information flow from these majority to minority networks. And this is by having a higher representative population than what you see in the US at the table of these majority networks, meaning we have to have more minorities at the same tables that these majority networks are at. And in this way, they can take this health information and share it within the networks of minority networks. To study homophily, we can use multiple types of social network analytic methods. However, one approach was to use a very special type of recruitment strategy called respondent-driven sampling. So to do a study on homophily and how it influences prep-related conversation among Latino men who have sex with men, including Black Latino men who have sex with men, we partnered with a community-based organization here in South Florida called Latino Salud, which is run by Dr. Stephen Fallon. A community health worker from Latino Salud reached out and identified one Latino man who has sex with men. This person then invited 3 of their friends, who then invited 3 of their friends. This contains one sociocentric constrained network of 13 gay and bisexual Latino men. We enrolled 10 of these groups into our study, and then we asked them questions. We asked them questions like, what's your race? Do you talk to this person about PrEP? Where do you live? And with this information, we're able to gather 3 important findings that I would like to share with you today. I would like to talk a little bit more about the analysis, but I don't think we have enough time. But this analysis that we use is a multiple regression quadratic assignment procedure, or the MRQUAT, for those who are interested more about it. So let me discuss each of my findings and offer some solutions on how homophily can halt HIV. Our first finding was that homophily on the knowledge of PrEP efficacy was associated with more PrEP conversations within these friendship networks. However, homophily on not using PrEP, meaning both people did not use PrEP, both friends did not use PrEP, resulted in fewer conversations about PrEP within these sociocentric networks. So what does that tell us? Well, that tells us that exactly kind of what previous research has told us, that in order to make sure that information is accessed and reaches these minority communities, we have to make sure that they have a seat at the table. We have to consciously include and prioritize minorities, minority health, and seek to eliminate minority health disparities. We have to bring people to the table. Secondly, we found that when friends saw each other more frequently or they felt emotionally closer with each other, they're more likely to talk about PrEP. This is interesting. It shows how people are multidimensional. We are not individual units making decisions, making health behaviors based in a void without any networks. This shows us that people are multidimensional. We are unique. We have different needs. And what this also showed us is that in order to account for the multidimensionality of people, we have to bring PrEP to the people. And this actually reminds me quite a bit of one of my favorite projects happening right now at the University of Miami with Dr. Doblecki Lewis. She has a PrEP ban. So what she does is she goes to the highest HIV incidence zip codes in Miami-Dade County, and she prescribes PrEP to those who need PrEP, to those who could benefit from PrEP. And this is a type of innovative intervention that we need to see to ensure that minorities have access to PrEP. Finally, we found that when people were homophilous for race, meaning they were both white, they were both Black, or they were both another race, that conversations about PrEP decreased. And when people lived closer together, conversations about PrEP decreased. People were less likely to encourage their friends to use PrEP. This shows us that we have a problem with stigma in the US. At first, this was quite conflicting for me to understand because all the other previous research has said, if you're the same race, if you have racial homophily, then you'll have more PrEP-related conversations. However, this is not what we found. So I turned to an expert in the social determinants of health, Dr. Tatiana Perino, and she suggested that perhaps these networks were just too overlapped, that this was a little too close to home, and people did not have the opportunity to talk about these very taboo and stigmatizing topics. So in order for a social network to halt HIV, for Homophily to halt HIV, we have to destigmatize taboo topics like HIV, sex, and PrEP. We don't stigmatize diabetes. And we know research has found that when somebody is diagnosed with HIV, if they are on medication immediately, and if they are virally suppressed, meaning that they take their HIV medications every single day, they cannot transmit HIV to their sexual partner. There have been multiple studies done with thousands of couples. Not one HIV transmission has occurred in these serodiscordant couples when the person living with HIV is on medications. This concept is undetectable equals untransmittable. So now I've told you that we have all the tools to end HIV today in the US. We have PrEP. We have U equals U. However, we still have 40,000 new HIV infections each year. What does that tell us? Health disparities are the barrier here. We have to address all the inequities in our society. We have to look to the history of the US and we have to identify how to dismantle these health disparities. Homophily could be an approach in which we can dismantle these health disparities, perhaps not only in the US, but also in the world. Thank you.